Board. So welcome everybody, this is Sue Grinnell. Happy New Year if I haven't spoken to you. So it's January in 2018 and we're all gonna do great things this year. So I'm excited. So I'm pushing record, so we're gonna record this. And I want to encourage as much dialogue as you feel comfortable with. We do have a chat box that's available, and I think please speak up if you have questions. I also want to remind you that at the end of this discussion, we'll be sending out an evaluation, so I'd encourage you to complete that. And why is this not? Okay, so I'm very excited that we have Jim Hester with us today. Jim is actually on the PHI board and has graciously agreed to spend some time with us today. And he's been very active in health reform and population health for almost 4 decades. And his focus on population health systems is the development of sustainable financial models that reward improvements in population health. And he's currently working with a number of communities, the state of Vermont, and also the CDC. He was previously a senior advisor to the director for the Center for Medicare and Medicaid and Innovation, so CMMI. I think you've probably heard of that, in assisting in the startup of the center, in the development of its initial portfolio of initiatives. And serving as the director of the Population Health Models Group, he was responsible for creating the Population Health Agenda for CMMI. So I think he has such a great perspective. And I was really fortunate enough when I worked in Vermont this last year, to have him as a thought partner in his involvement with our lab that we did. And what we want to achieve today with this discussion is to provide some background context on the Accountable Communities for Health model, and want to spend some time overviewing existing and emerging innovations in financing population health initiatives, and provide an orientation to this notion of a balanced portfolio action framework. So I think you're all familiar with the portfolio of interventions, which is an example of a varying, types of of interventions, and summarize, highlights of Vermont's population health components in this all payer model and the ACH initiative. And really, again, just want to have opportunity for questions and dialogue, because I know this is an area a lot of you are really interested in. Just in terms of your wellness fund and the issue of sustainability. So with that, I am going to turn it over to Jim.
Thanks, Sue. It's a pleasure to be able to chat with you this afternoon. The first slide, which Sue has brought up, so I'd like to give you an overview of where we're going through the main points. And the first one is that the healthcare system is in early stages of a major transformation to shift from one which is emphasizing volume to one that delivers the triple aims outcome, and particularly improve population health. The second point is that if the determinants of health, the things that really influence population health, involve improving, integrating clinical services with public health and community-based interventions, which are targeted on the upstream determinants of health. As you well know, clinical care, the medical services, only account for 10 to 20% of the overall determinants of health. And so if we're serious about trying to deliver a system, or create a system which improves population health, we have to be able to bring in those other factors, those other sectors, and be able to integrate with what we're doing with the clinical services. Third point is that the proposed financial model for improving this health, it involves a community integrator, which is really your accountable health community concept, managing a balanced portfolio of interventions, which is financed by diverse funding vehicles. One of the things that's been exciting about the recent developments in this field in the last 3 to 5 years is the emergence of new sources of potential funding and financing for paying for a wider portfolio of interventions targeted at other sectors outside of the medical services, healthcare services sector. And finally, this is a time of experimentation. There's a wide variety of experiments going on, both creating community integrators that have different names for them, and linking health and community development in a variety of exciting ways. So that's the main story. Let's flesh that out. Next slide. Next slide. So if you talk about the new measures of success for the system that we're trying to create, there are the triple aims: better health care. This is really focusing on improving the patient's experience of care. If you need care, it ought to be satisfied the Institute of Medicine's 6 domains of quality: safety, effectiveness, patient-centeredness, timeless, efficiency, and equity. We understand a lot about how to do that. The system's been working on that for a long time. And there's a lot of work going on in focusing on better health care. The second aim is lower cost through improvement. And again, lowering the total cost of care while improving quality, using improvement to identify opportunities for reducing the total cost of care. And part of the hope is being able to reallocate parts of those savings upstream to social determinants of health as part of one of the funding vehicles. The third one is where it gets interesting: better health. This is keeping patients well and focusing on well-being so they can do what they want to, increasing the overall health of the population. Well, we understand a lot about what's required to deliver better health care, and we're working on controlling costs. This focus on population health is relatively new, and it's where we're going to focus our talk this afternoon. Next slide. So one of the things that makes it complicated is that there are a wide variety of determinants of population health. This is a graphic that was developed by Matt Stiefel working at the IHI. It expands the traditional one that usually is used, the University of Wisconsin determinants health model. And I think it presents a nice picture of the wide range of factors that have to be dealt with, both socioeconomic, physical environment, genetic endowment. Matt got into the spirituality and resilience of the population, added that dimension, and it just sort of, it illustrates the complexity of trying to move the needle and improving population health. Next slide. I find that it's helpful to try to put the work on the population health work in perspective with the other work that's going on, important work that's going on in the health delivery system transformation. Neil Halfon at UCLA has come up with his healthcare 1.0, 2.0, 3.0 model, which sort of, I think, provides a very nice perspective on what the relationship of the various efforts are. Acute care system 1.0 is traditional, episodic, non-integrated care. And there's still important work going on in trying to improve quality at the episode level, avoiding hospital-based infection for hospitalizations, and improving the access and the effectiveness of individual visits. So that work goes on, but we've understood for some time that that's not sufficient. So the healthcare 2.0, which is coordinated, seamless healthcare system, instead of being episode-based, is patient-centered, person-centered, and tries to break down some of the silos between the various caregivers and different disease entities, and have a more integrated approach. This work is the work that's being done by such efforts and such initiatives as patient-centered medical homes at the primary care level, and accountable care organizations at the larger system level. But we understand that although this work is important, there's a third dimension, a third level of this transformation, and this is the community integrated healthcare system, healthcare 3.0, which is community integrated healthcare. This is not, if we're focused on the individual patient, this is population centered and uses population health focused strategies, learning organizations, and community health integrated with integrating the clinical services and population and services from other sectors in an effective way which addresses the needs of the population. So the move from 1.0 to 2.0 to 3.0, there's important work going on in all of these. Most organizations are focused on somewhere between 1.0 and 2.0, but the early adopters are trying to understand what's involved in developing a community integrated healthcare 3.0 system. Next slide. So in building a community healthcare system which will deliver 3.0 results, every system is perfectly designed to obtain the results it achieves. And so what you have to do is redesign the system. This involves redesigning at multiple levels: the primary care practice level, the community level, which we'll be focusing on today, the state and regional infrastructure, which support and enable what's happening at the community and primary care level, and the national support as well. And the approach that we've been using is start in pilot communities with early adopters. We don't have a scalable model that we can use to roll out throughout on a wide scale basis. And so we're still testing how to do this and creating the early adopters, the early examples of success in building community healthcare system. Next slide. So focusing in on the accountable health community, what is that? The accountable health community is made up of a backbone organization for governance structure and key functions. We'll talk about those functions in the next slide. But it also involves having relationships with intervention partners to implement specific short, intermediate, and long-term health-related interventions. No single organization, including the backbone organization, has the capacity and the capabilities that are required to implement the wide range of interventions that are necessary to address and improve population health. So the accountable health community will be partnering with a variety of information partners in order to do that implementation. Similarly, it partners with financing institutions who fund specific transactions and understands what the sources of funding are from those partners and what their needs are in terms of the types of interventions, the types of projects that are appropriate for them. So again, you have the backbone organization as a core, but partnering with a series of intervention and financing partners that will enable it to do its work. Next slide. So what are the functions of the accountable health community? What does it do? Its mission is, again, it's a community-centered entity responsible for improving the health of a defined population in a geographic area by integrating clinical services, public health, and community services. It does this by implementing a series of functions. First of all, it convenes a diverse set of stakeholders and creates a common vision for the community. What is its particular vision of population health look like? Secondly, it prioritizes the needs. This is the key thing. You need a community health needs assessment. You know, most organizations, most communities have done this. They understand how to assess needs, but this is the organization which prioritizes those needs, says, what do we do first? What's the sequence of things that'll get us where we need to do? And that decision varies from community to community, depending upon what the needs are, depending on what the assets are that it has in its starting point. Once it understands the priorities, it builds and manages a portfolio of interventions which address those needs in a systematic way. And again, we'll focus on this, expand on this in a few minutes. Once it's put that as part of managing the portfolio of interventions, it monitors the outcomes and implements rapid cycle improvements in the projects, including pulling the plug on the projects that are not delivering the expected results if that's necessary. It also has an important role in supporting the transition to value-based payment and global budgets. You know, having payment models which are based on value rather than volume is an important facilitator and important enabler of the population health work, and the accountable health community can be an important advocate for moving to that transition in a more accelerated way. And finally, it has a role, and it's trying to understand, as it is implementing the interventions in the portfolio, it'll probably identify gaps in community-based services that are needed in order to support the intervention and facilitate filling those gaps in the community-based services. So that's a rough overview of the kinds of functions that the accountable health community would support. Next slide. This is a schematic. As an engineer, I got to put at least one flow chart on the in the presentation. So this provides an overview of that backbone organization at the top. The financial flows are, it gets community financial commitments directly to the organization. There's grant funding that comes into the organization, but there's also a cycle of the backbone organization sharing in the savings, sharing in the results of the performance of its portfolio, and that's the red arrow coming into the wellness fund. So that one of the principles of the financial model is that examples that have been run and analysis been done of the different approaches has determined that it's virtually impossible to have a long-term sustainable financial model if you don't, unless you share in the savings. You can take some of the results, some of the performance improvements that are implemented in its interventions, and capture those and bring them back into the wellness fund for reinvestment into the community. That's a key principle that has been documented by a number of analyses. The lower part of the graphic shows the different types of interventions and being funded by different types of sources of fund, social capital, performance contacts, and savings from payments for services. And this is a high-level schematic. We'll be having a little bit more detailed example of the portfolio as we move into the next section. Next slide. So we're going to move into the second part of the presentation, which is really fleshing out the components of the sustainable model. Sue, I'm going to take a minute and just see if there's questions on the first part of the presentation, and to give a minute to get some feedback from people if they have questions.
Great. Thanks, Jim. Yeah, if you have any questions, please feel free to speak up, or you can put it in the chat box as well. So any reflections, thoughts, questions?
Hearing none.
Okay, well then we will move on.
So we're going to take a look at, first of all, a theory of action. Again, the key starting point is that it requires working at multiple levels: practice, community, region and state support, federal support. And again, the purpose is to integrate at the community level through clinical, public health, and community-based interventions. You need to have both operating revenue to support the interventions themselves, but also capital for infrastructure development to support the backbone organization, the accountable health community infrastructure, and make that, enable it to grow over time. There are multi-sector investments and benefits. One of the essential lessons of the determinants of health is we have to work in other sectors outside of healthcare, and so that there inherently is a multi-sector approach. And finally, as I was talking about earlier, the key thing is to capture a portion of savings and benefits for reinvestment for long-term sustainability. Next slide. Next slide, Sue. Hello? There we go. So the inventory financing vehicles. The starting point for this is there are two necessary but not sufficient building blocks which are lay the foundation for the financing. One is public financing for single sector programs. I'll give you some examples of that in a second. And also multi-sector programs which cut across sectors, either with a braided approach where you maintain the source of funds, but there's also blended approaches where you have sectors coming together and supporting interventions, supporting projects in a more collaborative way. The second initial building block is using value-based payment for clinical services and tapping into the savings of those value-based payments for the upstream interventions. Some examples of that are Hennepin Health, Medicaid plan in Minnesota that has successfully implemented this model, And Vermont is in the early stages of implementing a statewide program based on a CMS waiver that I'll describe as we get to the latter part of the presentation. People have talked about tapping into savings for some while. Next slide.
Hang on. So can you put yourselves on mute if you're not? I'm hearing a little bit of feedback. Thanks.
So these are some of the examples of public financing for single sector programs in housing, public safety, transportation, and education. A number of communities have been successful in tapping into these funds and developing them, using them to develop them in projects that support improving the population health. And again, there's a significant amount of funding that's available from that, and it's an important source to be understand and to tap into. Next slide. But there's the growing inventory of financing vehicles which are tapping a more innovative set of funding sources. At the hospital level, there are traditional community benefit funds that are being allocated, have been allocated for projects. But there's also a fascinating development of large healthcare systems such as Dignity Health, Trinity, Dartmouth Hitchcock, which have taken part of their investment portfolio, which is part of their endowment of the nonprofit organization, and using those as investments in community interventions, community-based projects, which are aimed at the upstream determinants of health. Dignity Health, for example, has allocated about $150 million, for these investment projects, which are separate and distinct from the community benefit work that it's been doing over in the past. The second source is the community development world. Just as hospitals have to, nonprofit hospitals have to provide community benefits in order to maintain their nonprofit status, financial institutions are required to have investments in the community and have contribute to the development of the community that they're servicing. The banks and financial institutions that are affected by this regulation have not wanted to have to manage these funds, manage these projects themselves. So they've created a set of new organizations called Community Development Financial Institutions, CDFIs, which do this work for them. The larger CDFIs, the more established ones, have portfolios of over $1 billion, $1 to $2 billion, very sophisticated project management and needs assessment skills, and have been doing some significant work in making investments in infrastructure in community, which support the economic development of the community. So there's been a growing recognition in this area, particularly from the Federal Reserve Bank in San Francisco, that there's a strong connection between having a healthy community and having an economically sound, an economically growing community. And so we're looking for opportunities for partnering the community development projects and organizations with the population health organization. More about that in a minute. A third source is social capital, where you're tapping the private investment, the capital markets, but you're trying to respond to the interest of some investors in having a social benefit to the investment that they make, so that they're willing to accept a smaller return on investment in exchange for being a social benefit. These are your social impact bonds, or another name is pay for performance. And again, I'll provide more information on that in a minute. Next, you have foundations, which in addition to their traditional grants those funding awards, can make program-related investments. These are, again, investments rather than grants. They're expected to provide a return to the foundations, and they're beginning to experiment with how to do this in a larger way. So the next one is employers. We found a number of several communities where the backbone organization has developed a strong relationship with major employers in the area, and that the employers are willing to provide funding and support. One of them was a subscription, which was on a per employee per year basis for the core organization. And finally, you have prevention and wellness trusts, which are being developed both at the backbone institution level, but also at the state level, with Massachusetts being an example of having funded a wellness trust for the state level, which is focused on supporting upstream determinants of health interventions. One of the issues on this is because of the variety of actors that are involved from in these various new sources, there's a more fragmentation, a lack of coordination, and there's a really important role for the accountable health community, the backbone organization, to develop the coordination and educate these different investors, sources of financing, and how and what the needs of the community are, and trying to do it in a more integrated and comprehensive way. If you want more on these, the Institute of Medicine Roundtable on Population Health has had several sessions on this fund financing vehicle, the development of new financing vehicles, and the dates are listed there. And there was another one just as recently as last December on how to use tax benefits and tax exemption benefits as a financing vehicle. So these together, these represent a very important set of new sources of money to support the portfolio of projects that are required to support to improve the health of the population in a given area. Next slide.
We have a question here. Excuse me. What's the range of return that bond investors or those program-related investments that you spoke of about foundations look for? And just wondering in those, what's the duration of the financial assistance, like how long they do it for? And just wondering about if the backbone is unable to generate those returns, you know, then what, right? So I don't know if you're going to get into this, but, you know, I think, so what's the range of return that they're looking for? That's the first question.
And the range of returns really varies widely. I don't think there's a simple answer to that. I think the important point is they are looking for some level of return. The performance of Dignity investment portfolio has actually they've had a comparable return to the rest of the portfolio, and their default rate is actually significantly lower than that in the other investment portfolio. So they have been able to identify a set of projects which have performed quite well. The social capital, again, it's clear that they're willing to take a lower return. There was a Goldman Sachs offering of $20 million for early childhood education project in the state of Utah. I think I remember the funding on that was for like a 5-year horizon, and I do not know what the exact return was, but again, I would expect that to vary from project to project, and depending upon the characteristics of the investors and the offerers. So I wish I could. The time frames tend to be in the intermediate time frame, 3 to 5 years. So it's not just 1 year, but it's not the long-term investments of decades that you find for other capital projects in the infrastructure world. But
okay.
Do
you have a sense of, just looking, because she had 4 questions, a sense of if they're not able to generate those returns, like what's the consequence, and you know, are these up for renegotiation? So oftentimes, you know, if you get a grant from a foundation, you can apply again and get additional dollars. I don't know if some of these are like one-time funding sources.
On the things like the social impact bond, if they don't perform, it's just like if they didn't perform on a traditional bond, the bond defaults. So you know, part of the initial offerings and getting this concept off the ground have involved backup in guarantees by foundations that at least guarantee a minimum return, so that that insulates the investors from a total loss, you know, to protect some of the risk. But again, there is risk involved in any of these investment models. And if you don't, risk means that sometimes you're going to lose them, some or all of the money that was put into it. So it functions just like a traditional investment.
Yeah. Okay.
Okay.
Good. Okay. Great. Thank you. Okay. Next slide. Right.
Next. So this is just fleshing out the details on some of the vehicles that we're discussing in the summary. The charitable hospital community benefit. I think most of you are familiar with this. Tax-exempt hospitals have to file an annual report on the community benefit. There's something on the order of 15 to 20 billion in federal and state tax exemption benefits. They tend to be heavy funding of use for ERs, charity care, Medicare losses. The time frame on these is annual.
Yeah. Jim? I think we got frozen. Uh-oh.
That was him.
I think he might have got cut off. For those of you that are on, I'm hoping he'll probably log back in. So I apologize, folks. It is like, he told me he had a wind chill of 35 below zero in Vermont. So maybe he's frozen. So just hang tight, everybody. I don't know. I can, you're back.
I'm back.
Uh-oh, did you get frozen?
It just froze up on me.
Yeah. Okay. Well, you're back. Yay. So you were talking about community benefit.
Right. So that's again, I think most people are familiar with this, but I just wanted to put it down as a type of a brief summary. The next slide.
Okay, hang on.
Yeah.
There.
Okay, so this is the community level financial institutions, CDFIs. I think this is one of the more exciting, new avenues or sources that have been developed. Again, it's tied to the bank's Community Reinvestment Act, in compliance with that Reinvestment Act requirements. It helps create subsidized financing to community development corporations and other investment projects in low-income areas. Its traditional emphasis has been on affordable housing, but it's been moving to support developments of grocery stores and other upstream areas. Their timeframes are longer term, intermediate to long term. The risk profile is that the CDFI functions to reduce the financial risk for projects. The status on this is there are over 1,000 CDFIs nationwide. They're weighted towards urban areas. There's been some major work going on, sponsored by the Federal Reserve and a couple of foundations, in trying to encourage the development of partnerships between these CDFIs and healthcare institutions who are interested in doing infrastructure development within communities. So I would encourage you to try to understand who the CDFIs are in your area, who are effectively within your region, and if you haven't established a relationship with them, to reach out to them and try to understand how you might be able to partner with them. Next slide.
Jim, I have a question that came in. Just wondering if you could speak a little bit more about the last slide on community benefits and just the notion that there's less money available for non-clinical interventions as the number of uninsured increases due to changes in ACA. I don't know, just kind of talking about what's happened. I think there's been a lot of trends that have changed in the use of community benefit. When ACA went into place, I think less of it was going to bad debt, but I think there, may be some changes there. So Just a little bit more on that. Yeah.
The expectation and actually the reality was that with the coverage improvements in the early stages of the ACA implementation, that the uncompensated care, unfunded clinical care would reduce because more people would have health insurance, and that would actually free up more money for upstream investments. With the recent changes, with the coverage expansion has halted, and it appears to be threatened. That's no longer true. And I just wanted that last bullet was just to emphasize that we really have to keep an eye on what's happening nationally with coverage and recognize that there are some consequences in terms of the availability of community benefit funds, for upstream determinants work, if the coverage improvements are in fact reversed. Is that enough?
Yeah, and I will put in the chat box, I sent out a note to all of you, another project that I'm working on, but it's a very new database. It's called hospitalcommunitybenefit.org is a website. So you could actually put in a local hospital and get a sense of, if they're a nonprofit, the amount of community benefit dollars that are available. And this was per the last data that we have is from 2014. We're in the midst of getting 2015. And then be able to see where are they spending their dollars. And I think it's just to tag on to what Jim's saying, when you were speaking about CDFIs, if you don't have a relationship with a hospital, I think it just, hopefully you do, but that, you're beginning some dialogue, and that's a good place to start.
And again, the hospitals are starting to recognize that there are benefits to them under a value-based payment model of making investments in the community. So you find hospitals starting to use some community benefit dollars for things like short-term housing for homeless population, so that people with chronic disease, homeless population with chronic disease, have a place to go to when they are stabilized and return to the community. So that we've had a number of examples in Vermont and in the rest of the country of, again, hospitals starting to recognize that it might be, and again, to their benefit, to use even community benefit dollars in more creative ways, which address the determinants of health. All right, so the last one is this, again, pay for success or social impact bond. Again, how does it work? It's a publicly financed program identified with known interventions and proven returns. The key starting point for this is you have to have a program which has, there's been enough research, enough work, the studies been done on it to demonstrate that it has a proven return, so that we can be the basis of the return of the capital to the investors. So it's a much more restricted set of interventions. That's a very demanding requirement that to get one which has this kind of evidence behind it. But again, it can be very useful within that sphere. It creates an investment model for returns, which is based on performance metrics and private investors to deliver the capital. So it is not dependent upon demonstrating the actual savings during the intervention due to the investment in the bond, but they have performance measures which are a surrogate for savings, and if you hit those performance targets, then they get the return on the capital. The time frame on these is shorter term, so intermediate term. As I say, it's not 1 to 3; it's more like 3 to 5 years. The risk profile, it's moderate. It needs some experience, but they also, to start off with, they've required in order to get them off the ground, they've required some risk mitigation by other sources such as foundations, in order to demonstrate the concept, demonstrate the model. This thing started in the UK, United Kingdom. There have been some uptake in the US in social sectors, and such as the criminal justice system, but it's early in the development in healthcare. There was again, the Goldman Sachs issue in Utah for the early childhood education. There was a smaller project in Fresno, California, for an asthma intervention, where they had an asthma intervention went into the community to mitigate risks for asthma in the community. But it's still in the early stages of development. That's it. Okay, next slide. So those are the funding vehicles. The balanced portfolio would tap into those different sources to create again, there's no silver bullet, no one intervention which is going to move the needle on the population, the health of the population, and address all the needs. So you're going to need a portfolio, a variety of interventions which are designed to meet those needs over time. So that portfolio of interventions will have a balance in several dimensions. One of the dimensions is the time horizon. You want something with short-term returns in order to give you some credibility and some early wins, but they're also important to do intermediate and the long-term interventions. For example, programs which reduce adverse childhood events, for children. There's going to be a balance in terms of the level of evidence. Yes, you want to, have low risk for part of your portfolio, but we also are in a state of development where we need to be testing innovative interventions and learning from them. So we need to be willing to take some risks in order to provide the evidence and learnings that's required to make these things successful. There's also a balance in terms of scale, the size of the project, the size of the intervention. In building this portfolio, the part of what the process is for each one of the interventions, building the business case. What is the evidence? What is the return? Who is and presenting that to the financing partner, and closing on specific transactions. This involves aggregating and aligning the financing streams that are coming in as for the portfolio as a whole, and managing and leveraging private and public investment to achieve greater impact overall. So that's the spirit of the balanced portfolio. Next slide.
Jim, there's another question here. I think it's a reflection class, slash maybe question. It's like this work requires quite a little, a level of business and organizational sophistication within backbone organizations. Like, what's your experience of how community backbone organizations acquire the capacity to do some of this stuff that you're talking about?
They grow it over time. Okay, and I think you try to build it over time, and the funding vehicles to support that are not, there's not a standard way of doing it. And my experience has been that each community, each backbone organization has a different story to tell in terms of how it's put that support together. But part of the story has been having a business, having the case, having the credibility that comes from having successfully done a couple of implementations. So you start by beginning with a couple of projects, and you build on that over time. One of the more complete portfolios that I've seen is with the St. Johnsbury, the Northeast, in northeastern Vermont, where the backbone organization there has been going for 5 or 6 years, and they've developed funding sources that come from the community, plus come from the hospital, and they've developed the capacity of the organization and been successful in implementing a number of interventions over time. So again, this is the conceptual model. We have examples of communities which are on this path, but I wouldn't say that there's any place in the country that is evolved to a fully sustainable financing model, particularly for the core infrastructure. So we're just learning what the sources are on this, and trying to develop some alternative models for doing it. The point about the backbone organization needing to have some financial capacity, some financial skills, is a key one. It's one that has not been emphasized very much in the existing literature, but I believe it's absolutely critical to the long-term success, of the backbone organization and of the initiative to improve health of the population. That we recognize that in addition to the community development and the planning and the needs assessment skills and sort of the thinking skills, that there is a financial component of this, which is absolutely critical. Part of this is understanding how the backbone organization can deliver added value to investment to the partners it's working with, which they would be willing to pay for. I mean, the example I like using is I'm on the board of a affordable housing corporation here in Vermont. This corporation, one of its important sources of revenue is it gets the developer's fee for putting together a project and identifying a financial partner and putting that package together and closing on the deal. It adds value to that transaction. And I think there's an analogy between that and what would be happening to the backbone organization as it moves into this model, where again, it is recognized as providing value. And so there's a transaction fee that is paid to it to help pay its costs for maintaining that kind of capacity. But again, we're in the early stages of doing this.
It is. So Jim, I got a comment that they missed part of what you were saying in answering to the question about how a backbone acquires the skills. I mean, you talked about it being over time, and that there was the success in St. Johnsbury in Northeast Vermont. And I think some of it kind of got a little garbled where it wasn't really clear. So I'm wondering if you could just speak again a little bit about, and I don't know, I'm the person who asked the question, Martin, if it was about St. Johnsbury in specific, or if there was something else. I don't know, Martin, if you want to unmute yourself and ask the question.
Sure. I think the sentence started with, a key backbone skill or capacity is, and then past that, I heard nothing.
I think
Oh.
the ability to understand what the needs of different investment partners are. An investment partner that is a CDFI will have a different set of needs from an investment partner that is trying to do a social impact bond, which would be different from an investment partner that we could be coming from a hospital endowment. So part of the financial skill is understanding the different sources of funds, what's important to those people, and again, demonstrating how the backbone organization can provide value to those organizations in identifying and implementing the interventions. Some of that would be the financial skills on a social impact bond. Often there is an outside third party which is really manages that process. It's more skilled in developing the performance model and doing the building the specific case and creating a specific transaction. So there's some of those financial skills will reside in the backbone organization, in the core organization, but some of them can be acquired on a consulting basis, on a case-by-case basis for specific transactions.
And or possibly membership, right? Partners.
Yes.
That are, part of the partners. So, Martin, did that answer your question?
Thank you very much.
Okay, great.
I'm having to be a little bit vague because there is not a clear model on exactly how to do this. I think what we identified as a need. The way in which we actually achieve that and build the capacity and build these relationships over time, again, that's what there's a lot of experimentation going on at this time in this stage of development of the model. Mm-hmm. Next slide. So this is a sample of a balanced portfolio for a community health system. The types of information going across the headings on the top. What is the intervention? What are you doing? The second, who is the target population? Third, who is the implementation partner? Who's actually going to manage the implementation of the intervention? Fourth, what's the financing vehicle that's being used to support it? Next, what's the time frame? What's the level of risk that's involved? And the savings, what's the savings sharing vehicle? How can the ACH share in the savings that resulted? So this tried to prevent sort of a spectrum of interventions ranging from intensive care coordination, which is focused on the medical society, medical services, and saving money on the medical services, to housing, to diabetics prevention, expanding early childhood education to reduce adverse childhood events, and community walking trails. This is every one of these examples is something that has been done somewhere. No community has put them together in a comprehensive way in this way. But again, this is meant to give you a little bit better sense for what might a portfolio look like, and to get you thinking about, for your community, where do you start? What are the initial interventions, and how do you begin again building the credibility, building the capacity of your backbone organization to put together a portfolio of this kind? Next slide. So as I said, this is a period of experimentation. We're creating working examples of this community integrator, accountable health communities. There's a rich set of experiments going on, including the work you're doing there in California on how to do this. How do you collaborate with the stakeholders, with innovators who are the source of these innovative financing vehicles? We need better tools, the analytic models for projecting impacts, particularly in impacts over time, and the measures for monitoring accountability and for supporting payment. We need a more robust set of the measures of the population health. And finally, we need to be able to do a better job of developing the evidence on the financial impact across sectors. Vermont, for example, implemented an opiate addiction treatment program. It made a significant impact on medical expenses, but it also, we believe, had a significant impact on reducing recidivism and criminal justice costs. And we've been trying to track down those savings as a way of demonstrating the cross-sector benefit of that intervention. Next slide. Some of the challenges, time frame. There's always a tendency in the existing system to try to find things which results in a year, in an operating year, and we need to have a longer time for these outcomes to realize their benefits. We need to be able to find ways of tapping shared savings from the medical and other sectors. The health sector needs to demonstrate how to provide value, again, demonstrated value to the financing sector, such as the CDFIs. And we need to do a better job of making the CDFIs and other sponsors aware of the community's balanced portfolio so that we avoid this fragmentation and some of the issues that would come up if we have multiple sources sponsoring projects in an uncoordinated way. Sue, we're running up against 5 o'clock.
Yes, or 2 o'clock here. Yeah, so I think, there's a couple more slides, and the slides are related to Vermont. I guess just given that we are, running out of time, I don't know if you have like, one of these slides that you want to speak to, or any kind of, just about your experiences in Vermont, and then just open it up for questions.
Okay, I'll just say that, why don't we go to start scrolling through the slide. Next one.
This one?
Nope.
Okay.
Next one. No, go back one.
Okay. Okay.
The all-payer waiver, we've negotiated an all-payer waiver with CMS for the state of Vermont that creates an aligned global budget payment model for Medicare, Medicaid, and all the commercial insurers. It's based on the next-gen ACO model. And it has explicit incentives for improving population health. Next slide. So there's 3 tiered, these are built into the signed agreement, 3 tiers of measures and goals, one based on the total population of the state, one based on just the attributed population to the ACO, the patients that it's managing. And there are also some process measures which are sort of shorter term. These measures are based on the Department of Health statewide health improvement plan and involve substance abuse disorder treatment, suicide rates, prevalence of chronic diseases, the requirement that the prevalence of the chronic diseases not increase over the 5-year period of the demonstration. And there's also a measure on access to primary care. Next slide. If they do not hit those targets, there are consequences. They have explicit defined measures. The way that you measure each one of these things is spelled out, and the targets are identified. There's regular monitoring of performance. If they don't hit performance, there's a warning notice with corrective action plan, and the performance is included in the payment model, using based on the benchmarks and risk sharing. So we were very excited to have population health outcomes built into this statewide payment model, and we're very excited to see how this works out in time. So I just thought you folks would be interested in seeing and knowing about this initiative. It's being implemented in the current year, and should be operational,
Uh-huh.
covering about 25% of the population by the end of the year. So in
And
addition,
it's nice to be in a state where there's less than 1 million people.
the other thing I'll just
Anyway.
mention is that we have had a statewide initiative in developing accountable health communities. We have these accountable health community backbone organizations under development in virtually all of the hospital service areas in the state. Sue referenced the work that she has done and the Public Health Institute has done in supporting the learning network of those HCHs. They're very different stages of development, from very mature to just getting off the ground, but we're excited about having a statewide network and see very promising advances in just a year and a half, 2 years we've been working with them. That's it.
Great. Well, thanks. So there is a question that came in. Any example of private sector participation for intervention, say partnering with Weight Watchers or like Fitbit, any other kind of tech companies in any of this work that's happening that you've spoken to, either Vermont or if you're aware of other places?
Well, the YMCA with their diabetes prevention program has been an excellent partner.
Mm-hmm. Great. Great. Any other questions for the group, from the group? There's a lot here. I feel like, on some of this, you could actually just have a longer discussion, I think, just on just some pieces of it. So I very much appreciate your time today. And we have recorded this, so we will be putting the recording and the slides up on our website for you to review again or to make available to your partners. Great. Well, thank you so much. Thank you, Jim. Stay warm.
Will do. Take care.
Yeah. Uh-huh.